the Biaxial problem-based instructional model in a pediatric residency program. Author, L Sénquiz, MD, FAM. Summary. Description. The Biaxial problem-based instructional model is applicable to cases admitted to the hospital as well as to those in ambulatory services. It provides for the development of a broad conceptualization of clinical problems and its progress. The model has 3 phases. Phase 1 is a case summary vignette that includes history, physical examination, and laboratories. Phase 2 consists of 2 axes. Biaxial algorithm. Axis A represents the working diagnosis. All working diagnoses are expressed in general terms. A holistic approach to the patient's illness is encouraged. This phase allows the student to provide immediate solutions to the patient's problems. Knowledge integration is accomplished. On axis B, the student works with all possible differential diagnoses based on the data collected. Synthesis and comprehension are accomplished in this phase. Phase 3 is a global review of the case in terms of the conceptualization of diagnosis, specific treatment measures, and pertinent cognitive material. Family orientation and educational material can be discussed in this phase. Following, the whole process is described using an insulin-dependent case to illustrate it. Please make reference to the example as the explaining remarks are provided. Process. The objective data that gives basis to the problems is schematically consigned at the vignette. This information arises from the history taken and the practice of a physical examination performed in a complete, exhaustive, and meticulous manner. The history of the present illness can be summarized with arrows that indicates the order of events. Patient below. 1 year old should include past history as part of the history of present illness. Depending on the development of the illness, days will be specified with reference to the date when the flowogram is done. Family history information can be supplemented with a graphic representation of the family structure by means of polygons containing vertices representing the members living in the same household. Working diagnosis, management, and the resulting emerging follow-up events are written down at the A-axis. Below the working diagnosis, treatment are indicated with a preceding dash. The follow-up of the therapeutic interventions are marked out with arrows. Corroborative tests are not permitted in the A-axis. Diagnosis should appear in hierarchic order according to the importance of the chronology. A working diagnosis can change, although this is unusual. In this case, the change is indicated with an arrow. Most frequently, it's modified or qualified as the result of the differential diagnosis process. In the case, it is indicated with broken lines. The differential diagnosis is worked at the x-axis. Once a diagnosis is established, it is incorporated to axis A with its pertinent treatment. Not all working diagnoses require the differential diagnosis elaboration. Emerging arrows from the proposed diagnosis are used at the differential diagnosis axis. This will indicate the study, laboratory, criteria, application, or strategy used in order to rule out or to corroborate the diagnosis. Afterwards, another successive arrow is placed to reach the conclusion or the diagnostic clarification. When a process has not ended, the arrow is left in place. A diagnostic strategy can be the application of some specific criteria. For example, Jones criteria for rheumatic fever or Kawasaki's criteria for mucocutaneous lymph node syndrome. When a diagnosis is reached through the B axis, it is moved to the A axis as a new working diagnosis, separated with a broken line. It can also be integrated to an existing working diagnosis, as it is shown in the IDDM example. The concept of differential diagnosis in this model includes the consideration of possible complications. See IDDM example. B-axis DF-DX, electrolytic disturbances, cerebral edema, hypoglycemia. If there is a new differential diagnosis not derived from axis A, it is incorporated to the axis B. When a working diagnosis is established, it is incorporated to the A axis under a broken line. At phase 3, the following components are provided. A. Conceptualization. It is an explanation of the diagnosis process, providing interpretation of the material appearing in the biaxial algorithm. Synthesis will be the preponderant, though skill to be expected from the student at this stage. B. Cognitive enrichment. The student will search for cognitive material. He will present the obtained material in a creative manner through the use of tables, enumerated notes, graphic organizers, and concept maps. C. Family orientation window. The material developed in this area can be applied directly or indirectly to patient and family. It will be characterized by the use of a simple, understandable, non-technical language. It should be indicated as part of the praxis at axis A. For the evaluation of clients with psychosocial problems, I recommend, although it is not a requirement, the following organization by areas. 1. Physical. 2. Cognitive. 3. Mental. 4. Stressors. 5. Global functioning. Cultural and spiritual aspects should be given their consideration. Patients at the intensive care unit will have the differential diagnosis worked by systems: cardiovascular, respiratory, neurologic, gastrointestinal, etc., establishing the vigilance of possible complications in addition to the etiologic differential diagnosis. An example of the biaxial problem-based instructional model. Phase 1. Analyze the following areas. Present illness. Example: 8 years old admitted with diagnosis of insulin-dependent diabetes mellitus de novo. Family history. Unknown. Past history. Unknown. Early childhood, was abandoned by parents and placed at a foster home. Immunizations were updated during 3 years. Physical examination. laboratories. Phase 2, Biaxial algorithm. In this phase, we are going to draw the biaxial algorithm. Phase 3A, conceptualization. Excerpt from an educand. The principal problem in this clinical situation is the lack of family resources. A child with diabetes mellitus requires, in order to receive adequate management and prevention care at home, a compromised and properly educated family. Since this patient is living at a foster home, caretakers will demand special attention as to the details of the illness and the impact of optimal care. Program implementation. Model. Number 1. Theoretical aspects conference. Number 2. Discussion of several examples. Number 3. Workshop with examples brought by the students from their experiences. B. Implementation of the model. 1. Presentation of cases with the application of the model. 2. Group or individual discussion. Feedback, establishment of problem using the biaxial algorithm, establishment of the differential diagnosis following the biaxial algorithm, demonstration of the capacity to do a conceptualized synthesis and development of cognitive enrichment activities, holistic focus. In this part, multidisciplinary approach. Invitation to the discussion of other health professionals that need to intervene in the presented case. B. Identification of resources in the community. Identification of educational areas for the patient and his relative. In this part, identification of community resources. Number 3. Rehabilitation. Number 4. Psychosocial aspects. Number 5. Spiritual needs. Letter C. Assessment of student. Cases presentation, quantity, variety, and complexity. Instructional model utilization, holistic view, systematic use of steps. Problems solution. Holistic multidisciplinary education. Competence test. Number 2, instructional model. Effectiveness in problem solution, applicability to a variety of cases, use of model by the educand, variety of alternatives for the solution of problems. In conclusion, the biaxial problem-based instructional model is essentially an instructional method. However, if used as a work tool, it will also allow for a panoramic view of a complete picture of clinical problems and course. It can be actualized as the patient conditions progresses. It constitutes a simple method to provide an integrated and summarized information of clinical problems with conceptualization, cognitive enrichment, and family education, which are important elements of the medical practice, as it creates pragmatic pathways of management, provides the conceptual and organizational basis for the future development of a book containing a pediatric medullary curriculum.